a routine for nitroglycerin, which tells you when to seek emergency care. Questions about angina? Okay, moving on. DVT and PE. Remember, DVT is a deep vein thrombosis and a PE is a pulmonary embolism. What is the difference between a thrombosis and an embolism? Right, thrombosis is stationary, embolism is on the move. Okay? So for a DVT, the pathophysiology, remember we're looking at that Virchow's triad. And so we're looking at stasis, and that's where the blood slows. That flow of blood slows down. Then we have that endothelial injury, and that's where we have the vessel damage. And then the hypercoagulability. Because of that epithelial injury, the platelets are going crazy, right? They're like, oh my gosh, something is happening, we're bleeding, I gotta stop it. So it swarms in, and that's where we start having the clot, okay? So, going from there, the clinical manifestations, let's talk about the DVT first. So you're gonna have pain, tenderness, swelling, red discoloration, warm, difficulty walking, and no pulse in the extremity for a DVT. Okay? For a PE.
Would you also have a positive Homan sign?
Yeah. Positive Homan sign is for a DVT, yes, but remember we talked about in class how that is not always true. You can sometimes have false positive. So they don't do that. They may look at it, but that's not going to be the only definitive sign that they use.
All right.
Make sense?
Yep.
Okay. All right, so then for the pulmonary embolism, remember the pulmonary is talking about the lungs. So we have things that are going on with the lungs. So we have sudden shortness of breath. Their O2 sat is going to decrease. And remember, you're probably going to see a decrease in O2 sat even if you're giving them oxygen, because there is something truly blocking that flow. And then sharp chest pain, you're going to see an increased heart rate and a decreased blood pressure. And remember, this is when the patients are having that impending feeling of doom. You know, I am really worried something bad is about to happen. And then hemoptysis can be seen here, and that's just coughing up blood. So those are your clinical manifestations for each one of those. So a lot of the DVT things are going to be aimed at prevention. So with that, we have early ambulation, the SCD hose, the SCD device, the TED hose, adequate hydration. Remember we talked about increasing fluid intake because we don't want our blood to get sticky. So the more fluid volume it has circulating, the better off it's going to flow. And then the LMWH, that stands for low molecular weight heparin. You may have already knew that, but there it is. Low molecular weight heparin. That is for prevention. Now, if we have
the shots in the belly?
yeah,
Okay.
yeah, that's your heparin, Levinox, things like that. So remember, if we have a confirmed case of a DVT, what do we not want to do? SCDs. We don't want to massage, and we don't want to put on SCDs because we don't want that clot to break free. All right, important labs that we need to look at is the D-dimer, and that means a positive result indicates the presence of a clot, but it does not predict the location. Okay, so you have to go by assessment findings and other imaging tests to decide what the location is. Risk factors: increased age, prior clot, birth control pills, that's a biggie for people of childbearing age, and immobility, especially after surgery, which is why we do early ambulation, right? Again, nursing diagnosis is aimed at gas exchange, breathing patterns, tissue